given us some more strength that probably the journey that we have been continuing for the last 1 decade is probably right. So in this context, we'll see what is the current status of CT coronary angiogram. So what we are going to discuss in next 20-25 minutes is what is CT coronary angiogram, why it is required, and yesterday we had seen why it should be done, when it should be done, and how it should be done. So in this talk, we will see some literature review, and we'll see the work that has come from this institute, and we'll explore with some examples. So there is, as we all know, this coronary abnormalities are the hallmark of Kawasaki disease, which in acute form can be in the form of aneurysm, dilatations, and on follow-up there can be stenosis, steno-occlusive lesion, calcifications coming up. And thanks to IVIG and other immunomodulation drugs, that has decreased the incidence of coronary artery abnormalities to less than 5%. Having said so, if the abnormalities develop, then they need close monitoring. So as of now, there is no unanimity, and this is different in the different parts of the world. To begin with, it was catheter angiogram, then shifted to echocardiogram. Now with the evolving technologies like CT and MR, they are getting integrated, especially during the follow-up. And the guidelines are, as of now, are somewhat silent on its use in the acute phase, and we are trying to fill in that gap. So these are the imaging modalities that we have been discussing last 4 days. Echocardiogram is a standard of care. Catheter angiogram is a gold standard, and was used to be the investigation during follow-up. But thanks to CT and MR, that has given us new hopes, and they are emerging and the new modalities. So once we talk of any modality, we need to see whether they are feasible, what is the technology. So I always say, when you consider anything, you need two things. You need equipment and you need expertise. So until you may have expertise but you don't have equipment, then you cannot do it. And if at all there is a technique, whether it is susceptible in a particular age group, so these are things that we need to consider. So as far as CT coronary angiogram evolution is concerned, it was only possible after the advent of multi-slice CT with 64 detectors. And that was the remarkable year. And when it was 64 MD CT, it was restricted only the adult coronary arteries, but the radiation was in the tune of 6 to 10 millisieverts. But its integration into the pediatrics, as when we had discussed with Professor Sujit Singh, he had happened to attend the IKDS in Southeast Asia, and there are some people, he told me that there are some people that were discussing the role of CTCA, but they thought it will never come to pediatrics because of high radiation and the inherent high heart rates. But thanks, with the time, things evolved, and the CTCA became reality in the pediatric domain as well. So let's see, when we talk of new, it has to be seen in the context of the prevalent or the standard of care imaging modalities, whether it's echo. Rakesh has discussed very explicitly. Echo is the standard of care, no doubt about that. It has to be, and it should be, and it will be. But we must understand that the coronary artery, though prevalent in the proximal arteries, it is not that they cannot occur in the distal segments, or they can occur, that doesn't involve branches. And we must understand this is an operator dependent. Angiogram, we have been discussing, we cannot subject our children, especially during follow-up, the catheter angiograms. Every day, 3 years, 5 years, we cannot subject these patients for catheter angiograms. MRCA, we have discussed long acquisition times, and it is restricted. MR is a very specific examination, irrespective of the part that you image, whether it's brain, whether it's pancreas. It is not something like MR abdomen. It has to be very specific. So it takes long time. In CTCA, in this context, seemed very attractive because of its short acquisition time. Excellent isotropic imaging with brilliant temporal and spatial resolution. And so with these conditions, there were whispers that whether it's scope, whether it's feasible, the radiation was always a concern, and the strength. These were the things then how we began with. But definitely, you see when we had multi-detector CT from 64 to 320, C60, thousands detector CT, and for that matter, two tubes orthogonally placed dual source CTs had largely addressed these questions, and that how this technology came into the pediatric coronary imaging in Kawasaki disease. But you see how the coronary artery disease can be is different from the adulthood. Adults coronary heart rate is usually less than 80, but in children have inherently high heart rates. So you cover that innately high heart rate, your scanner has to be very very fast. And if you scan but your image quality is not proper, then it's a futile investigation. For that you need high spatial resolution, means the image has to be very very clear. And more importantly, when you talk of these things, if it is not radiation optimized, probably it will never come into the pediatric in the practice of pediatrics. So everything has to be met. So thankfully, these things are largely addressed now. So when these things came into picture, the CTCA slowly started moving its baby steps towards its role in Kawasaki disease. So initially, if you see the literature before 2013, it was limited only to the case reports. And the concern was the radiation and the image quality. But when the 128 first generation scanner came, probably in 2010, there was first series that came from China and published in 2010. And what this study this concluded is it was only on 16 patients, and they told it can have it can detect the middle and the distal segments and has good correlation with the echocardiogram. And they concluded that it was accurate, non-invasive, and maybe a valuable technique for detecting as well as on follow-up of the coronary artery lesion of Kawasaki disease. Since then, there are multiple publications that came up, and this publication was in the British Journal of Radiology, and it unambiguously said that there's an agreement with CTCA and the transthoracic with a good correlation, and same thing we are trying to do in our institute as well, and it has an excellent image quality with low radiation exposure. So during this time, we had our scanner in 2012, second generation dual source, and we also started our program. I don't know how it started, how the thoughts came, that I leave to, I have no answers for that. And in 2015, then again, we had a comparison, because when you start new, everybody is going to ask, does it meet the same criteria? Does the measurements mean the same? Does your imaging findings are the same with the established modalities? That was catheter angiogram, and the measurements were showing good correlation, you see. And that's how, things starts accepting into the
studies by Dr. Suda.
Yes, ma'am, Suda study. Yes. Sorry, ma'am, I couldn't, I didn't, pay that attention. This is a study from Madam Group that the CT angio and the catheter angiograms are in agreement as far as finding as well as measurements are concerned. So, this is how, Madam, this group, told you CTC is better than coronary artery angiograms in detecting thrombus. If somebody asks me what is catheter angiogram, I will say it's the imaging of an contrast fill lumen. It will not tell beyond lumen. So if you want to see the mural abnormality, you need to have cross-sectional imaging. And it can detect wall thickening and calcification that Arun has also showed, and we will see in the next few slides. And they have, made an remarkable comment that CTCA using dual source CT is non-invasive, accurate and safe technique for measurements of coronary artery abnormalities immediately after acute KD. That's why, we have seen many questions arising in this forum, that when CTA should be done. Now the consensus is building up. I think in the days to come, things are bound to change. Then there was another publication that was Insights of Imaging, and that also, reviewed literature on the role of CTCA and KD. And they, at this time, they had advocated the use of low dose CT or with the invasive catheter angiogram. And you see how the things change when everybody is in consensus, and consensus come when it has something to offer. Then in 2013, you see there is another paper that came in Journal of JCCT. I think this is from again from China. They said कि coronary artery abnormalities Singapore. Okay. So they say technological advancements of coronary CTG has led to shorter scanning times, low radiation, improved image quality, and they probably they were pretty sure that it can help in detecting the myointimal thickening versus complications, stenosis, occlusion, thrombosis, and they slightly touched upon the coronary artery abnormality detection in the acute phase. And since we started our work, we simultaneously started our publications. First publication came in 2018. At that time, we did know what we was doing, and we were struggling to write our manuscript. And first publication came in current problems in diagnostic radiology, followed by I had an opportunity to write an article with Madam Suda that was on the International Journal of Rheumatic Disease. Then we had a review article in Global Cardiology Science. And recently we had articles in Lancet, Rheumatology Oxford. We have few images on Journal of JCR. Recently we have been publishing in World Journal of Clinical Pediatrics. Recently we got an invite from the Archives of Childhood Diseases, and this article is in press. So this is what this has happened and what we have been doing as a team here. If you have to go to the CTCA, let's go into the subject proper, what is strength and what is evidence like. So everybody probably are in agreement that, Kawasaki disease can involve any segment, any branch of the coronary arteries. And if you have to talk of echo, which is a standard of care, is limited for diagnosing middle and distal coronary involvement. And CTCA gives, the information along the entire length. LCX, which maybe is difficult to evaluate because of its course and anatomy on echo, is very well seen on CTCA. Diametral correlation we have already seen with the thoracic echocardiography as well as catheter angiogram, so there is no ambiguity about it, and it tells about the aneurysm morphology, extension, complications, and no doubt it is the investigation of choice for follow-up. So these were the first scan that we acquired in the day of 28th November 2013. So this slide I always will show in any of my presentation. So this was the first, presentation. I was very anxious. Probably I may not have slept the day before because this was the first case. And when the case was acquired, I was slightly happy that, at least we can get good images. So this time the imaging was retrograde. We never tried adaptive because we never wanted the examination to get, and I was not confident even. So when this scan was done, first question that was asked, radiation कितना आएगा? Sir, radiation 2.2, no, it's ज़्यादा आएगा. It's more. So I think how to reduce it, I had no answers. But slowly, first 30 cases, I requested, sir, let's do it. In the times to come, we'll change to it. And then finally, we started to adaptive ECG gating. And since then, we didn't look back, and the radiation has already been in acceptable levels. So let's see with some case examples how CTCA has been helping our clinical consultants as a problem solver. Dr. Sandesh is here, probably we saw this first case. So, if you see in this case, what you see is this is LMCA, this is LCX, LAD, LCX, and this is RCA. Okay. So what we saw, you see here is, if you have to go by the Z scores, the LMCA was diagnosed as dilated. If it is a dilated, you have to augment your treatment therapy. Once the child stabilized, we did a CT angiogram, and what we found was this was single coronary artery. Remember, what Arun has showed is there are two coronary arteries to start with, right from right coronary, left from left coronary. If all the circulation has come from a single artery, by virtue of nature, it has to be big. So if this is a constitutional large artery rather than a pathological large artery, if you know this, you discontinue your therapy. Parents and patients, you can see smiling faces, and it is so revealing. So this is a problem solving tool. Another thing that you see is this dilated RCA. Palvi is here. I don't know Palvi is here. No. So what you see over here in this image is a dilated RCA. Okay. Then when we did in CT coronary angiogram, what you find is an L kappa. This is in left main arising from the main pulmonary artery. When this will occur, there will be a shunting between the low pressure and the high pressure beds, and the RCA has to dilate. And when the RCA was dilated, we know it was not pathological, not pathological for Kawasaki disease, and this patient was having LV dysfunction. And this patient was discontinued with therapy and was operated in time. I think Rakesh is here and he will tell you the story about that. And he has recovered very well and with improvement in the LV functions. So with this, we thought once you start doing it, then your journey becomes remarkable. We started seeing the distal coronary arteries, and these were our eye openers. And we curated our data on 176 children about the role of CTCA in diagnosing distal aneurysm, and this was published in Rheumatology. And yesterday in the dinner, Dr. Sandesh was telling me, sir, manuscript ke citations bahut ho gaye hain. I mean, yes, there are, this is one of the most cited our publication about the role of CTCA as far as distal aneurysms are concerned. So we'll see some examples with this. This is not a rocket science that this dilatation will not be seen on echocardiogram. But what about the distal extension? Distal extension can only come through, the CTCA. You can see this aneurysm, but you cannot see the branch vessel involvement. Measurements are pristine. Yesterday I was discussing with the CMC Vellore team, sir, what about, Dr. Murugan is going to present about the correlation between the CTC and echo. The measurements on CTC, I think they are the way forward. And because they are, variably inter or intra-observer variability, and days are not far when we have automated detection software to take care of that, some variability that may exist. You can have discontinuous aneurysms. You may detect proximal, but middle and distal you cannot see. You cannot see the basal wall in monument. This is how the CTCA comes in the picture. And if you talk of Madam Suda's group, and these are the patient who needs follow-up, close follow-up on CTCA rather than echo. You can have distal aneurysms. You can see this distal aneurysm, branch point aneurysm. You can have dumbbell belt aneurysm. You can see this one, but this may not be difficult to detect. And this was the patient that Dr. Rakesh was discussing yesterday, isolated RC aneurysm. There was no aneurysm or abnormality in any of the proximal coronary arteries. Then this patient we discussed yesterday was have a relentless course. You see pleuropericardial effusion, pericardial window has to be created. All the arteries was dilated. You see the pan-coronary involvement. And this child we just did an MR on this, doing very well. You can have, aneurysm in the distal branches. This is an OM1 branch of the obtuse marginal. You see a bunch of Graves appearance, very nicely seen on the other curved reformated images as well. So these aneurysm by no imagination can be seen by echocardiogram. Then you can see this complex aneurysm arising at the branching point, going into the proximal LAD, going into the diagonal wall, involving the ramus intermedius. And you can see there is no hypodense filling defects, even that can tell you that there is no thrombus. Then you can have the complex aneurysm. You see this, this we lost this child very recently. So this child had, developed a large, I will show you that follow-up image, then we'll discuss at that time. The LCX, you can see the distal aneurysms. Complications you can see in the form of hypodense filling defect, in the form of this thrombi here. It is a small volume thrombus. You can never detect on echocardiogram. This is a small filling defect over here. And you can see the, images. Sureshji, can we have this lights? You can see this, can you see this filling defect over here? Same you're seeing on this image. Then you can see complications in the form that, this is a calcified aneurysm, and calcification is a killer of ultrasound. Air and calcification. You will not see anything if there is a calcium and the air. So these aneurysms you cannot never see on whether it's proximal. You will not be able to see on echocardiogram. So either you need a catheter angiogram or you an MRC or CTCA. Echo is out. So you see this example that we discussed yesterday. So this was an acute presentation. This is an LAD which is thrombosed, and you can see subcollaterals. There is a large aneurysm in the RC as well, and you can see 1/3 of the ventricle which is aneurysmal now at the apex. And you see about the status of this RCA, large giant aneurysms. You see I've never seen this big aneurysms. This was a delayed diagnosis. Then you can see morphology that we have discussed in the previous case, how the branch vessels can be involved. You see the morphology of this aneurysm, see this large secular aneurysms. This is fusiform aneurysm. Why we are interested in this? Because these fusiform aneurysms are, more prone for complications because of altered hemodynamics. And these are the reconstruction images that you can see about the contents of this aneurysm. Then the important thing that is coming, how to now, we are at this stage, now we have started getting the follow-ups also. 2013 to 2015, 12 years our journey, now we have started, getting the follow-ups. So I will show you this example. This patient had aneurysms in the proximal RCA, whole of the RCA was aneurysmal. This was a complex aneurysm. Then after 3 years of follow-up, you see only the aneurysm are restricted to the proximal RCA. And you can see the large LED aneurysm has remodeled, and you see in small aneurysm which is showing some calcification. No stenosis whatsoever. This is a patient on follow-up that we show, and on this follow-up what you saw is this. You see there's a tight stenosis at the proximal LED, another tight stenosis at the mid LED. Ma'am, you were asking is sensitivity and specificity. What can be more specific than this? And these are the patient, once you know this, yesterday we had seen lecture of Dr. Suda ma'am when to consider myocardial perfusion imaging, whether it be in MR or myocardial perfusion imaging. So these are the patients who require myocardial perfusion imaging. If there are defects, then patient has to be intervened either in the form of whatever the treatment that we can offer. So this child was an athlete and mountaineer. Used to love mountaineering, and suddenly he collapsed when he was, climbing. So we have trying to integrate. This is the example that I showed previously. At now, after 3 years of follow-up, what you see, large calcifications has come up. These aneurysm has remodeled, you see. But there is, there may be some suggestion of some stenosis, especially in this LED segment. So we are planning for myocardial perfusion imaging on this kit. You see these images, heavily calcified. Calcium score, you see it's, Tapas sir, you were asking me the calcium score. The calcium score is 551. The calcium score is more than 80 years in this 10 years. You see how severe is the calcium burden. Then we always see, till yet we have seen all the cases which were diagnosed as KD in the childhood. But as an adult cardiologist, sometimes you see abnormal coronary arteries, which you cannot define that they are atherosclerotic. So before this, the first data that came was from Dr. Professor Jane Burns group that was on catheter based. So in 2015, we, with our adult cardiologist, curated or analyzed 11,000 CAT data, and we found 4-5 patients which was of probable missed KD origin in their childhood. So with that same data, we started seeing our CT angio data prospectively. And you see there are some abnormalities which tell that they were probably missed KD, because as madam was telling in the morning as well, KD is a self-limiting disease. At that time, they might have KD, they might have fever, they might have taken some antibiotics, things might have resolved, but they continue to keep symptomatic. And when they are symptomatic, they will come to us for CT angiogram. And what you see is over here is, you see these arteries are dilated. This proximal, you see the proximal RC is dilated, distal RC is dilated, the proximal LED is dilated. This dilatation, this skip dilatations, you will never see in atherosclerosis. So probably this is missed KD. So we called their parents, asked them very specifically, did this child has this type of disease? So out of 5, 3 was categoric, no, they had this kind of symptoms. So we attributed this probably due to Kawasaki disease, and sir had suggested to keep them on aspirin. So this manuscript is already accepted in press. So we have 5 cases like that. So this again a missed KD of childhood. This is aneurysm. This is calcified aneurysm. Calcification only restricted to the aneurysmal segment. There is no differential diagnosis. This cannot be atherosclerosis other than the Kawasaki disease. Now with this we have discussed. Now the $1 million question comes of the radiation. So we curated our data for the radiation as well. The radiation across the age groups we calculated, and the radiation was well within the limit of 1 millisieverts, especially in the age less than 1 year. As the child will grow, our more is the body mass, more energy we have to give. So the radiation may slightly increase more than with 1 mole sieverts. So this is a journey, and this is the experience of the leaders across the globe. And we have discussed our experience as well as of CTCA. And we are quite happy, contented that this modality has now started seeing the light of the day and helping our community. Now, with this, should we stop here? No, lot many things are there to offer. As of now, we are only seeing the morphological images. Can we have some hemodynamic information on these aneurysms that can predict about whether they will increase, whether they will decrease, whether they will have calcifications, whether they can have a thrombi? So then the time has come from move from morphological images to functional assessment. And the functional assessments can be on the flow dynamics. And with this, when we talk of these morphological images, we talk of hemodynamic changes, then everything will be individualized then, and that's the time that has come. Every patient is different, every lesion is different. So basically we are also working on this subject, and hopefully if everything falls into place, we will have that assessment as well. And these are the things that you can reconstruct: wall shear stress, hemodynamic stresses, pressures on the things, on the aneurysms, on the walls, for prediction of the future cardiovascular events. So with this, if you see, CTCA non-invasive investigation shows CA along the entire course, along their long branches. If you have to compare with catheter angiogram, it detects the mural abnormalities as well. It delineates the temporal change of coronary artery abnormalities, which may be in the form of resolution, stenosis, thrombi, mural calcification, remodeling, and more importantly, as a pediatric cohort, the radiation exposure is acceptable. And more importantly, it has an excellent correlation with echo and angiography, which is now beyond doubt and well established in literature. So with this was our statement 5 years back, potential to become a standard of care. If you see the 2024 guidelines, they have integrated the role of CTCA, but they are using the word can be considered. And I think in the next guideline, this can be will be changed to should be considered. And in my personal opinion, it should be considered. As of now, it is restricted to follow-up, and its role at initial presentations remains silent, both in the guidelines. Let's see how can our experience can help the community. So with this, I think I should finish, and questions, if any, please welcome.
Thank you.